Hello, Houghton, MCPAP Program Management Specialist, and I'd like to welcome you to the MCPAP Clinical Conversations take place on the fourth Tuesday of each month from 12:15 to 1:15. Today's topic is MCPAP 2.0 Program Enhancements to meet the needs of today's pediatric practice. Before I announce today's presenters, I'd like to go over a few housekeeping rules. The session will be recorded and available on the MCPAP website at www.mcpap.org. A copy of PowerPoint slides will also be available on the MCPAP website on the Archived News and Webinars page. We will be meeting this webinar on Thursday, December 15th at 7:30 a.m. We will also be sending out another invite for that webinar. There will be time at the end for questions and comments. If you have a question or comment, please either type in the chat box during the presentation or click the hand icon, and we will read out your question or unmute your line to enable you to ask your question. Also, we'll receive a very brief survey following the presentation. We appreciate your feedback to help us improve future presentations. Today's presenters are Dr. John Strauss, the Founding Director of MCPAP. He is the Director of Special Projects at the Massachusetts Behavioral Health Partnership, where he led the design and implementation of MCPAP. Dr. Strauss is one of the founders of the National Network of Implementation of MCPAP. The National Network of Child Psychiatry Access Programs, an organization designed to promote the development, sustainability, and quality of child mental health and psychiatry access programs designed to address the mental health needs of children and adolescents within a primary care setting. Dr. Strauss is a pediatrician, having had a primary care practice for 22 years. Dr. Strauss did his pediatric training at Strong Memorial Hospital at the University of Rochester and was a Robert Wood Johnson Clinical Scholar at Johns Hopkins Medical School. Also speaking today is Dr. Barry Sarvet. Sarvet is the Chief of Psychiatry at Bay State Health in Springfield, Massachusetts, and Professor and Chair in the Department of Psychiatry at the University of Massachusetts Medical School at Bay State. He helps to guide the development and implementation of MCPAP since its inception in his role as its statewide medical director. Dr. Sarvet has written numerous papers and delivered many presentations throughout the United States on the topic of child psychiatry in primary care. His state and national professional groups has been devoted to the advancement of the role of child and adolescent psychiatrists in collaborating with primary care providers. In addition to his leadership and academic activities, Dr. Sarvet spends a significant portion of his time in the clinical practice of child and adolescent psychiatry and consulting with pediatricians through his MCPAP team at Bay State Medical Center. Before we begin, I'm just going to make sure that Dr. Strauss and Dr. Sarvet are on the line. Okay, Dr. Strauss, may I begin?
Thanks, Mary. Just before we begin, I want to make sure that we can see if anyone has any calls. Can we see at the same time?
Yes, we can. Yes, we.
Okay, great. Well, thank you for joining us today, and we're very excited to begin talking about what we're calling MCPAP 2.0, which is our, we've been doing MCPAP for 12 years, and are now very excited to begin to think about sort of the next phase. And first, a little bit about how we've gotten here over the last year. Last winter, we hired DMA Strategies, a consulting firm, to do its strategic assessment. Some of you may have even been interviewed. A 360 press to look, interview, and get information from people who interact with MCPAP from all different areas. And based on that strategic assessment, we came up with a strategic plan, which is available on our website if you would like to read it. Based on that strategic plan, we then sent out a request for information and then a request for proposals. We over the summer, that procurement process occurred, and we selected the vendors who the providers, most of whom know, will bring us in to provide MCPAP 2.0. And Barry Sarvet do a little background, and Mary Servette will just to summarize the strategic assessment, and then Barry will talk to you about the new programs going forward. As part of the assessment, there was good news, obviously. Recognized that MCPAP was a groundbreaking solution, was highly regarded, replicated nationally, and people very satisfied. But you can always make improvements. So there were challenges recognized. There were perceptions around some of the abilities for us to do care coordination, and we'll talk a little bit about that as we go along. On the realistic expectations that we at MCPAP could fix all the ailments of the behavioral health system. And there's the opportunity for improvement because of the variation that was found across some of the teams. And all this was in light of the changing healthcare environment, which particularly the movement towards ACO and value-based payment. Some of the recommendations that came out of that we incorporated in our redesign was to refine our mission, clarify our role within the general children's behavioral healthcare system, and make enhancements to the model to more effectively respond to that healthcare environment. With that, I'm going to turn it over to Barry to begin to talk about what our new design looks like as we begin. And just keep in mind that this will be starting January 1st, which is very close. Okay, Barry.
Thank you, John and Mary, and hi everybody. So I'm gonna start in here and talk a little bit about the new 2.0, as we say, and I think one of the themes is that there's quite a bit that's staying the same, and there are some significant changes that we want to have a heads up about. But the bottom line is that the mission actually, we had not necessarily articulated this but the mission is staying pretty the same. That MCPAP is for pediatric care providers. It's really a PCP facing program, and actually we're starting to think about not providers, but we're thinking about primary care teams, and really wanting to offer our services to support primary care teams, knowing that it takes more than a person to do behavioral health. That it really is something that requires leveraging a team in the primary care practice setting. So it's one change that is included in the new mission statement. But again, it's really founded on the principle that behavioral health. We all believe that behavioral health is a fundamental aspect of health wellness overall, and that we want to support the primary care team and being able to do all the things that are part of best practices in terms of taking care of mental health issues in the primary care setting, which includes screening and identification, early identification, assessment, at least the medical aspects of treatment, coordinating care, being effective referrals, and really kind of being a medical home to patients with mental health problems over time. And so that's pretty similar to the way we've been running, but we want to articulate that. And I think a key difference is this notion that we need to connect to teams and not just to specific individual providers. Slide, Barry. And so we're going to go through some of the goals of the plan, and this is growth of what John was talking about in terms of the recommendations about changing and going into a little bit more granular detail about this. So the first is accessibility for face-to-face assessments throughout the region. That's the same. We want to be reliable and maintaining a continuous supply of these services and have the right number available and maintain our response times for these things, which has been 2 weeks, and at times it has not in the past been possible for us to offer within that time frame. Like to preserve really this relational model, that we want PCPs to be able to talk to a limited group of consultants, and so that they can form really personal, individualized relationships with the MCPAP consultants, and we want there to be continuity of care. We really would like to be able to do more shared care. We're actually work with you over time, patients, and we've never actually thought of ourselves as just a one-time consult service, but we've wanted to be available, and we want to make that more clear that this is it's a marathon, not a sprint, so to speak, and that we want to be with you as you're taking care of these patients, and then there may be return consults that are provided and repeat telephone consultations. We want to be more data-driven and build in more performance improvement into our own work, and also help PCPs do that as well, really moving towards data-based tracking the outcome through data and measurement-based care. Number 4 is actually related to the changing healthcare environment and acknowledging, and really recognizing that PPs, and primary care practices are no longer really just isolated businesses. That they're members increasingly of networks. Not everybody, of course, and but more and more networks exist now than had existed before, and so we'd like to actually align ourselves with the goals of these networks, particularly COs or practice networks and health systems, so that we can complement their efforts to try to provide population health approaches to their patients. Number 5 has to do with just the fact that even though we know that MCPAP doesn't work without a system of mental health services that's healthy and functional surrounding it, and that there are ongoing issues in terms of the performance of the mental health system and the resources and the accessibility and the coordination of them. But we can't fix all of that, as John pointed out, but we can be the eyes and the ears of the system, because we'll be in a position to knowing where the gaps are and what some of the issues are, like whether it's patients being discharged from psychiatric hospitals without aftercare plans, whether it's different kinds of deserts throughout the state where there aren't psychiatric specialists for the patients who are more complicated, whether there's a lack of therapists for certain special populations or certain areas that really are under-resourced, that we want to be able to feed information to the systems at the state level, so that people can address these kinds of problems. Next slide, Mary. So the collaborative care model, actually we should probably have put in the term models, because there's lots of ways to skin a cat, and there are different ways that networks and practices are learning how to address mental health issues in primary care, and so we want to support these models, and one of the models which we'd like to see grow in children's mental health is the so-called collaborative care model, which is a model that has designed for adults, but we believe can be adapted to child psychiatry, and this really has to do with leveraging embedded who are in the practices to become the teams, and then working with consulting psychiatrists to review and to support registry-based tracking of patients, as well as just the whole notion of using measurement-based care and really treating patients to target in the practice setting, particularly mild to moderate degrees of severity. And so we want to promote that and support that. And we really want to try to help practices to kind of transform themselves to meet their own goals as far as, how they want to implement, in primary care, which goes well beyond just answering questions about patients and helping to provide consults and helping to advise on treatment plans. It really has to do with helping practices to develop the capacity to screen, to track, to do care planning, to really maintain longitudinal relationships with patients, and so we call that practice transformation, and that's one of the functions that we'd like to see MCPAP, getting into beyond just answering questions. And it's a little bit more of much more of a proactive approach as opposed to just waiting for people to call us. Number 8 is guideline-based care that we're actually really interested in developing a set of guidelines that we can utilize both for training purposes as we go out to practices and teach and do webinars and different kinds of educational programs, but use in all of our consults. That when we do consults, we want to use the consults as usual as kind of a way of teaching people how to take care of these kinds of mental health problems. But we would like to also to use the consults to reinforce these kinds of clinical guidelines. So that every time we do a consult, it'll to clinical guidelines and reinforce the learning process about how to take care of these patients and promote consistency and some degree of standardization, knowing that children's mental health doesn't always fit into neat categories, and that there's still going to be a lot of creativity, but we still want this overarching framework of being consistent with clinical practice guidelines. And we are actually going to be utilizing some internal resources and so to speak, that we have within our program, because we have one of our teams we'll talk about shortly is going to include more of a substantial role for a children's hospital, Boston, and have the luxury of having Heather Walter and Dave DeMasso, who have actually done an enormous amount of work to develop clinical practice guidance in the context of their learning communities, which is part of the POC model of integration. And so we're going to be benefiting from the involvement of David and Heather in terms of helping us to develop these guidelines, and all the teams are going to be involved in looking through them and trying to develop a set of guidelines that's user-friendly and based on evidence-based practices. Number 9 is the tracking coordination of care, which is really part of being a medical home, and implications for how we provide the care coordination function are embedded in this thing, and we'll talk about this a little bit more detail. But we are changing the way that we're going to be providing the care coordination service that will maintain similar kinds of resources and we're going to help you in similar ways, but we do want to reinforce the notion that MAP has never really been resourced to the level that would make it possible for us to assume responsibility for care coordination for your patients, because that's really a function that belongs in the medical home. So we want to support practices in developing their own processes for care coordination by either with recent navigation and as well as doing direct resource finding, and helping people get appointments for certain kinds of criteria having to do with risk and complexity. But we do want to reinforce the notion that practices need to have their own models and mechanisms and functions built into the medical home for the true care coordination, because this has to do with really maintaining a relationship with patients over time and knowing they're getting the care that they're needing and helping to troubleshoot their treatment plans and things like that. And then finally, the last goal is really we would like to be reliable. Consistency might not be the right word, but really reliable. We want people to know, when to get, from MCPAP, and we've had some variation across the teams that we're trying to address, so we can really be reliably providing, what we say that we're going to provide in the program. Slide, Mayor. Okay, so a few more slides, about, just some of the concrete things that are changing and not changing. What's not changing is that, we have the same sites. All the sites that had been participating in MCPAP are still going to be participating in MCPAP and offering the MCPAP services, and particularly for the face-to-face assessments, because we want the face-to-face assessments to be geographically accessible. We are going to be adding more telepsychiatry capacity so that we can help people who might have a hard time getting to these sites. Even though we have many of them, there's still some patients that have to travel too far to make it really accessible. Most of the psychiatrists and team members are staying the same, although there will be some changes based on the reorganization. But by and large, the same people are MCPAP as people, and we have the same people. Same telephone consultation model, same response time, same hours of operation. Next slide. So this is a big change. So we've had 6 hubs in the past, and now we have 3 large regional teams. We're actually using the term hub, at least at the moment. We decided that team is a little bit more apt. And so these are bigger teams and bigger service areas. So we have 3 teams. That we really have actually two teams in a sense, because the Eastern team is a mega team, but it's made up of 2 teams, and functionally it will be experienced as being really 2 teams in the East, just from the standpoint of having a site to relate to, that every practice will know which of the sub-teams that they are supposed to call, for teleconsultation. Some of the face-to-face consults will be delivered in a way that might not be according to the team that you call for the teleconsultation, because we want to emphasize the need to make the face-to-face consults geographically accessible. So there will be a little bit of complexity in the East around the teams and where people will go for their face-to-faces, and we'll be trying to make sure that that's not unclear to people. The West and the Central teams have merged, and so we will have one Western team with 2 sites of service. Each of these 3 teams, or whether you want to call them 2 teams, with teams, but basically 3 call centers that are going to exist, and you'll see the phone numbers at the bottom. And so this is a significant change that involves some new relationships. So if you're in the West, you call the hotline for the West Central team. There are some days when you'll talk to people that you haven't talked to before, and you'll get to know people at the UMass team when in the past you only spoke to all the Bay State teams. Now we are limiting the number of consultants so that it's a manageable number, because we don't want people to have a diffusion of that relationship. By having 20 people across a big large team. So each team has a limited number of people, so that we can make sure that people have consistency in these relationships. Next slide. Change, I alluded to this, has to do with, this notion of being mindful and trying to complement integrated behavioral health initiatives that are network based, and sometimes practice based, or both really. That there's practice based change that's going on, and then there's network initiatives, involving integrated behavioral health. And so we get into this space so to speak, of really helping practices to transform themselves into effective medical homes for mental health issues, and also to help to reinforce and really strengthen the efforts of networks to develop models of integrated care. And then, affiliating with these networks and really becoming partners to the networks as well. The largest of which for children is the PPOC, but also in the West, Bay State, Pioneer Valley, ACO has a children's ACO as well. And then other ACOs that are both adult and children, have large numbers of pediatric practices involved and are interested in and in the process of developing integrated behavioral health models. Slide. Just changing. Talked about this. I talked about the guidelines, I think, as much as we can right now, and those guidelines will be developed over the next 6 to 12 months. In terms of care coordination, maybe this is the time to really talk a little bit more about that. That we're changing the model for care coordination. In fact, we're changing the name of it, and we're really calling it resource and referral. Actually, the next slide has that. Thank you, Mary. So resource and referral name, and it really reflects the point that we don't think a remote, centralized program should think of itself as a provider of care coordination, because that should be practice-based. And so we're going to have two kinds, basically, of resource and referral, two levels. One level is where we give advice to the primary care team about how to find services that are needed and to navigate the system. And might be, we know there's a short waiting list at this particular clinic, or we know that there's a Spanish-speaking therapist. We know where you can find a CBT therapist currently, and we're actually going to leverage a resource that's been developed by Margaret Hannah's team at Project Interface, who've been partners with us around really developing care navigation tools and building databases and things like that. So we're going to give advice as opposed to doing it. Sometimes practices nowadays call and say, okay, I have 5 patients, we need therapists for all these patients. Here are their names and numbers, and thank you so much for that. And it's not that we don't want to, but it's just that that's not scalable for the state, and it doesn't work as well as it should. And so that's one level, is really giving advice. The next level is what we've done in the past in terms of, we are willing and interested in actually calling families and helping them to get appointments and working with them and trying to get in. But we're trying to restrict this to the ones where you really need us to do it. And these are potentially more high-risk referrals where there's a level of urgency, or if there's a referral that we think is more complicated that isn't going to be possible for a non-specialist, to make. And so there's some programmatic services, and there might be some delicacy involved in trying to get the services arranged, and so we're willing to do this traditional notion of trying to get the services for people and working directly with families for patients based on criteria, which we're going to develop and disseminate. And then, we're going to try to, through this outreach model, try to help you to develop communication processes in your practice, so that you can take care of these issues at the practice level. Yes.
Just to add, one of the things that came out of the strategic assessment was our recognition that when we were doing a lot of the care coordinating, when we split up, the patients weren't getting there. And we weren't doing a very good job of that because we didn't know the patient. and at times we may not have had the right cultural competency to help those patients get to where they need to be. So we're hoping that as we build this in the practice, the practice will be able to work with the families in a way that will be more successful than we were able to do centrally.
That's a good point, and I guess I'll make the point. Maybe this will come up in the discussion, but also we're mindful of the fact that practices don't have extra people sitting around, to do more work these days, and so it might not feel as if it's so to speak, for the practices to the care coordination themselves and to help to make appointments, for patients for mental health and really guide them through that process. But so some of this is really resource driven, that we don't have the funding to provide an adequate capacity of care coordination that would serve all the practices. But the idea is just that it's better for patients to have this embrace, of a primary care team, helping them to get the services they need and to guide them through that process. That is the patient-centered medical home model, and there's a lot of validity to the notion of this being provided at the practice level. But we don't kind of have a fantasy that it's going to be easy for practices who don't have, the resources and to do this. So we're going to be planning on trying to struggle with you around that, and we're not going to be, extremely rigid, but we are going to be trying to move forward to have a more coherent model of research and referral that is based on the principle that care coordination is a function that really should be within the practice, and we're just going to try to help you with that in different ways. I guess the other two columns on this slide is that one of the reasons, we should have said this earlier, I suppose, but one of the reasons for reducing the number of teams, that we realize that the teams are potentially more complicated and they might feel more somehow impersonal, because they're larger, and there's a nice folksy sort of homey quality to the small team, and every practice has this small group that they know they can connect to. But one of the big reasons why we changed to this small number of teams is because we wanted to be able to have two child psychiatrists who are on duty simultaneously at any given time, and we had we still have our limited amount of funding, and so we wanted to really have a dedicated presence of a child psychiatrist to be online, to be available, so that we can more consistently provide a rapid response time. And the only way to do that, that we discovered, was to really be able to consolidate the teams, because if you have 6 teams, the call volume was such that it wouldn't be appropriate to have that dedicated role. That you have a lot more multitasking, where a child psychiatrist is on the line answering phone calls, but is also seeing patients in clinic and doing evals and things like that. And that led to a lot of inconsistency in response time, which is not in keeping with our pragmatic kind of mission to really provide the real-time ability to telephone consultation. And then that also frees up some resources so that we can send people out to the practice for this so-called practice-focused education training. We call it practice outreach. One of the terms that we're using is really a practice liaison. And I think that's the next slide. If you go on to the next slide, that we about second bullet, that we want every practice to have an individual who is their liaison as a child psychiatrist, and the liaison role is to help you to identify the goals of and the needs that you have, needs and goals about how to become more adept, providing mental health care in the primary care setting, and this notion of practice transformation. So in what ways does each practice want to transform? Do you want to get better at screening, or do you want to learn how to do care coordination more efficiently, or do you want to start to incorporate registries and develop registries to track your patients, or do you want to hire an integrated behavioral health clinician and you need some help and consultation around thinking through of what the role of that clinician might be and how to prepare your practice for this, or you want to develop more relationships with referral sources surrounding your practice, etc. And so some of it might be we need to learn more about how to treat anxiety disorders or how to treat patients' autism or whatever. So the liaison is not meant to be a Swiss Army knife, person who can necessarily personally teach you all the things that you need to learn, but as the person who might be able to teach you some of the things that you need to learn and might be able to connect you to resources that we're going to be developing for the state in order to try to provide some of those training functions. So it's a liaison, and the liaison might organize special interest group kinds of meetings, to discuss cases. I don't know if people have heard about Project ECHO, but the ECHO is kind of curriculum-based sort of peer learning model with instructors who talk about different topics and develop a curriculum to really strengthen one's knowledge on a specific subspecialty topic. It started with hepatitis care, adults, but also involves this peer learning and peer support as well as mentorship model. So it's that's another thing that practice liaisons could potentially do, is to start to organize some groups, to talk about different topics related to mental health and primary care. So that's pretty much the liaison role, and I think that's one of the structural issues that is going to make PAP 2.0 seem different from 1.0. I think some of the other changes are they may not be as substantive, but I think there are enough changes that we really think it's helpful for you guys to hear about this and to try to wrap your heads around it, so to speak, because we want people to have a smooth transition in terms of how they relate to us, and because again, from the first point that I made is that PAP has always been and continues to be for pediatric primary care providers and teams, and so it's really about trying to help you to meet the needs of the mental kind of morbidity, and the patients, with morbidity in your practices, and to incorporate that into your setting. So that's I think that's about it. John, do you think we should add anything, or I'm not sure if others are unmuted on the leadership team, but are there any other points that we should emphasize before we open it up for questions? I think we have about 20 minutes left.
Well, just one thing I might add to the liaison role is we also think that you may be able to use that liaison person to do case runs, to talk about the cases that you're having difficulty with. You might set up a regular time, let's say at 8 o'clock Thursday morning, once a month, to talk about cases, and the folks will have the time to do that.
Kind of an echo-y thing, as they say, in terms of Project ECHO, and I think that's an example of some of the kind of things that we'd love to see happen, with these liaison relationships.
Project ECHO tends to be around specific illnesses, whereas we would be very happy to help just with problems, cases you're having problems with. We got one question, which is what happens to the old phone numbers? And for old phone numbers, we'll roll over to the new ones, but eventually we will, whatever the phone system. I think you get a year with you being able to use the old phone numbers. Eventually, we'll have to use the new ones. But certainly on January 1st, you won't have to worry that if you call the old number, you won't get anybody. Another question that's come in is how are you going to how those liaisons going to be assigned? You'll be working with your current teams to figure that out, and you may know some of the people, and that's great. And if you we'll assign, but some of that'll be a ongoing discussion with your current team.
So John, I don't see any of the questions, so if you see any that you'd like me to answer, just let me know.
Yep, so anyone who has a question can either type their question into the chat box on their right-hand panel, or they can click the hand icon next to their name, and we will unmute you. So we'll give people a chance to type in their question. We have a question. 2 new phone numbers were listed. The phone number for Bay State and UMass and Boston were the same. Is that correct?
After that slide,
yeah,
can you back up to the slide?
That's slide number 11.
Maybe we misprinted.
I have 3 numbers on there. Oh, 2 numbers. Look at that.
Oh, that is a typo.
That is a typo.
I apologize for that, and I will correct the slides and send them out to everybody so that everybody has the correct numbers. But as a kind of reference, every practice will receive a mailing that will include all of their information, including the number that they will need to call.
Sure.
Thank you.
Lee's rating these.
Bay State, UMass, the western one is right, the Boston and South.
Questions or feedback or concerns or things that you like? I mean, we're definitely interested in getting some feedback and kind of having a sense of how people feel about some of these changes.
Okay, a couple of questions have come in. One is the social worker role, and we don't see that changing. The social workers will continue to both sometimes answer questions if they're not addition level question, and they will continue to do face-to-face assessments when that's appropriate. I think the question came in, Barry, you might want to answer this around particularly with respect to Jody, and I don't know if everyone knows that what's happening with Jody.
So, the question, is there more detail on the question, or just the general thing about what's going on with Jody?
They would still have access to a G type thing.
Yeah, so I can speak to that. And it's a Western issue, but Jody Devine is a therapist who was from the very beginning. She helped to basically had the first team that started up, and so Jody has been an institution for the Bay State team, and so she actually decided that she wants to do some different kinds of work, and so she's made a move to becoming an integrated behavioral health clinician, to working in a primary care practice as an embedded therapist, and she did that. She's staying with Bay State, in our system, and she did that purely out of an interest in learning new things, but it's gonna be a big loss because Jody's been a wonderful member of the Western team, and really has been such a resource to the pediatricians and to all of us out here. So her role is going to be the same, and we are in the process of recruiting a therapist to take her place. And so all the teams have access to a therapist for clinical consultation, for help with triple P, for example. We've been providing some triple P counseling on a short-term basis, and we are, the role is the same. So both telephone and face-to-face consultation can be provided by a therapist on the team, although the default, if someone asks to talk to the therapist, then they certainly will be up to the therapist, but the default hotline will be staffed by one of the dedicated child psychiatrists, so that'll be available within the response times that we've promised.
Okay, a question that's come in is the ability to do face-to-face consult changing, and it is not. The criteria for doing the face-to-face will be the same. We hope that with this new arrangement, the response time will be better, but the criteria is the same. And the I think Barry sort of answered this, but let us do it again, which is if the practices are now more responsible for making therapy appointments, we have up-to-date information about who is taking new pediatric patients based on insurance. And yes, we will be keeping track of that, and you always be able to call and find that information from us. And we have access to, as Barry mentioned, to the Williams College Project Interface database. And we might think about ways, if we know of something. I think one of the things is, have you know of some things in a referral resource that you're used to using? We might think of ways of letting you guys know that proactively if we know that. Does anyone see anything, we don't want to, does anyone see anything we've said is going to cause any problems? Oops. Is there going to be a need to re-enroll? Not normally. All the practices that have been using us will roll over. As Mary says, we'll be sending out information. We do expect that as the liaison folks are being with each practice, that those folks will reach out, make sure our information is up to date and your needs being met. And so there's no formal re-enrollment, but we will be checking that the enrollment information we do have is accurate. Anything else? We're looking let go. That you'll get after you hang up, you'll get a survey key from us. You have a few closing messages? Yeah, I just wanted to thank everybody for joining. And if you have any additional questions after this webinar, you can email us at mcpap@beaconhealthoptions.com. I have a question come in. Whoops. If practices who have been used to using us to make these referrals are now having to do it themselves, that's going to cost some money for staff. and the grants available. I don't know of any actual grants, but I expect this to happen overnight, because practices is not going to be practical, and we'll continue to do much of what we've been doing, but we want to begin to transition, and you will be expected to transition as you become a patient-centered mental home, and as payment models change, where you're having capitation or some other kind of value-based payment, the expectation is that you'll be able to do that care coordinating. You'll have money in that payment for those kind of services. But that's going to be a gradual process, and we would expect some practices are already really there, and others are working on it. Okay. Well, thank you, Barry, and please let us know if you have other questions come in. You will be getting a mailing, and this webinar, if you want to listen to anything again, will be posted on the website.
Thanks, everybody.